everybody. Welcome to our webinar, to a live presentation and Q&A with Dr. Jonathan Ford. In our webinar today, we'll be exploring digital sleep dentistry and the Panthera sleep appliances. I'm Steve Karstensen, Chief Dental Editor of Dental Sleep Practice Magazine, a MedMark media publication. Before we get started, I want to make sure you see the chat box on the side of the screen. That's where you can enter your questions. And Dr. Ford has a great presentation for us today, but he really wants to emphasize that if you have a question about something that can help you in practice, please interrupt or put your chat there, and I'll bring the questions to him either in the middle or at the end of the presentation. We really want you to come away with something that you've learned tonight. At the end of the webinar, we'll email all attendees instructions on how to access the replay as well, so you can catch up on something if you've had to take your eyes off the presentation for a moment to type a question into the chat box. So let me introduce Dr. Ford. Jonathan Ford attended the University of Pennsylvania School of Dental Medicine, where he earned a BA and graduated with cum laude with honors, scored in the top 5% of the country on his national dental boards, and honors in pharmacology and therapeutics. Along with continuing his postgraduate education and advancing his understanding of dentistry, Dr. Ford is an active member of the ADA, California Dental Association, Orange County Dental Society, and also a diplomat of the American Board of Dental Sleep Medicine. He's given grand rounds lectures at Long Beach Memorial Hospital, which stressed the importance of oral health and overall health, and spoke on behalf of the California Dental Association. He served as president of Huntington Beach Kiwanis and volunteered his time doing dental clinics at orphanages in Les Sayas, Haiti. Dr. Ford, you're eminently qualified to help us with our practice questions, so I'm happy to turn the webinar over to you.
Perfect. Thanks for that introduction. I'm going to get my slides up. There we go. So let's get straight to it. I'm a big believer that there's certain points, certain moments in our life that kind of help us or train us to do better and to kind of overcome those fears and hurdles that I think all of us as dentists have in their day-to-day practices. About 15 or 20 years ago, I had the opportunity to do a semester abroad in Australia, and a couple of my buddies and I got to take a road trip in New Zealand, in the South Island of New Zealand. And we had the opportunity to go bungee jumping at the place where they started bungee jumping. It's in Queenstown, New Zealand. And as we get to the place, you get those nerves, that anxiety of you're going to be doing something a little bit scary, but also a little bit crazy. We get up to the place where they start strapping you in, and they strap me in, and I stand up, and then in the background, I hear the really uplifting music of Gangster's Paradise starting to play in the background. Just what you want to hear when you're about to jump off a little platform. I kind of get up to that edge, my feet are tied together, and they start that countdown, 5, 4, 3, 2. And when we get to 2, they pause, and we don't go to 1. The bungee jump operator stops and says, wait, take a step back. I don't think I double knotted you. And I'm looking at him like, are you really serious at this moment in time? And he's like, yeah. So I have my feet on the edge, and I kind of have to hop back. My feet are tied together, so it's not this graceful movement, and I'm teetering on the edge of falling over. And I kind of step back, and he has me sit down, and he looks at my feet and he goes, oops, I'm sorry, I didn't double knot you. So now I'm thinking to myself, do I trust this guy? Do I trust the technology? Do I trust the bungee jump? Do I trust and kind of overcome my fear and anxiety and kind of do this? And I had this kind of split second moment that I'm like, I'm here, I'm gonna do it. Let's do this. So he wraps me back up. Gangster's Paradise is now blaring in the moment. I get back up to that edge, feet literally on the brink, and he goes 5, 4, 3, 2, and I kind of wait at 2, wondering if 1 and 0 is coming. He goes 1 and 0, and I jump. And all of that fear and that anxiety of built up over the last 5 or 10 minutes turns into an amazing amount of fun. For me, digital dentistry, I had to take that leap of faith off the bridge and trust the equipment, trust the bungee jump, trust the operator. Digital dentistry was very similar to me. I trusted it, but I still had this apprehension and I still had this fear. When I took the leap of faith into digital dentistry, I didn't want to just tip my toe in the water. I kind of wanted to do a cannonball in the deep end and really turn that fear into a bunch of fun and take that leap of faith. It's been an amazing ride since I did that. I've had Omnicams, I've had CEREC machines, I've had 3D technology like Cone Beam. We now have 2 prime scans in our office and they're being used every single day. So, and that fear to fun, that leap of faith really has I remember that moment, and I try to, if I have that fear, whether it being using a new sleep appliance or using a new composite or using a new implant or doing an implant or doing your first sleep apnea device, you have to get comfortable with that fear and know that on the other side of that, in almost in a matter of seconds, it can be a lot of fun, it can be a lot of rewarding, it can be profitable, but you can also, especially when we talk about dental sleep medicine, we can be saving patients' lives. So today we're going to be talking about digital dentistry and how that's helped, how I've leveraged that and got introduced to Panthera, how they are really on the cutting edge of using digital dentistry and fabric and 3D printing their appliances with their 3D printed proprietary nylon. They have a super robust CAD/CAM software to design the sleep appliances, so they are completely customizable, something that I don't think any other dental sleep medicine device, oral appliance therapy, mandibular advancement device on the market has, is all these customizable features to make the overall patient experience and patient outcomes significantly better. So, like I said, the video was about 15 or 20 years ago. This is me taking that leap of faith, and these bungee jump operators have it down to a science as long as they double knot you. But when they get you up on that platform, they ask you, how far into the water do you want to go? Do you want your hands to touch? Do you want your head to touch? Or do you want to be completely submerged when they drop you off that? So having the faith in the technology and taking that leap of faith has been a huge part of kind of how I've transformed my practice to where it is today. I also like to show this video as well, because I think it resonates for dentists, general dentists, or any dentist kind of getting into the dental sleep medicine world. So, real quick, simple video here is just watch the team in white and how many passes does the team make. So the answer is 13. But if we rewind the video and start taking a big picture look, we miss something quite obvious. And this, I think, is especially particular with the field of dentistry right now, is that we look at the big picture, we obviously miss the moonwalking bear. As dentists, I think we're so focused in on the teeth and the periodontal charting and the gingivitis versus periodontitis, and are we going to crown this tooth, and are we going to do a filling, and how do we design the stuff? We don't look at the nuances of the tongue, of the throat, the transverse dimension of the arches, and all of those things that if we're not educated on what to look for, we can be missing out for the patient's best interest. I think we as dentists have the ability to be catching sleep apnea long before the medical world does. Size of the tongue, scallop tongue, all these minor things that if we're not educated and we don't see it, we can't essentially talk to the patients about it. So it's really important to start looking at things. And my goal today is for at least, whether it be just for you guys getting into the dental sleep world, is how to screen patients. I'll go over briefly on what I look for. But just to take one or two nuggets from this lecture, or one or two things that you can see differently, or educate you differently, therefore you see differently, and then you can treat your patients differently. So it's starting with education. When you educate, you can see. When you can see, you can diagnose. And when you can diagnose, you can treat. It's that pipeline that I like to do for myself and for my team and for my dental practice. So that video, real quick, is one of the mantras that I like to live by, is the eyes don't see what the mind doesn't know. And I think that's what that video shows for me, or hopefully that's what it showed and you guys can see, is if we can't see something, or if we're not educated, we can't end up seeing it. So one of the big things that I've invested in myself is my education. When I can start getting my brain in tune, I can start seeing stuff. And when I start seeing stuff, I can treat a lot more stuff. The next mantra that I have is the best investment you can make is an investment in myself. When I started investing in the technology, and you're going to see I'm a little bit biased with my intraoral scanner being a prime scan and being in the CEREC world. I don't care what you're investing in, right? Whether it be a Trios or iTero, invest in yourself, invest in your team. And when I was able to do that, I really was starting to get an infinite return on my investment. Every time I started making dental sleep appliances, there was an investment in my education then, but now I can repeatedly do that over and over and over again. So I can make 4, 5, 6, 7, 10, maybe if you're a huge dental sleep medicine, 20 sleep apnea appliances, mandibular advancement devices. And this it can apply to dental sleep medicine. It can apply to oral clear aligner therapy if you get into Invisalign or SureSmile or ClearCorrect, or even implants. If you start investing in your education, you can start adding more procedures, and that you can then do over and over and over again. And then I talked about that. The first thing I did was the bungee jumping. Is how do we get comfortable being uncomfortable? How do we start doing these procedures that we've really never done before? And I kind of joke, I do this for multiple reasons, but every employee in my office, we're getting them sleep tested, and every employee's spouse gets sleep tested in my office at no charge. And the reason I do this is, one, if they have sleep apnea and I treat them, they're going to come be better employees in my office. If their spouse has sleep apnea, they're probably making a lot of noise snoring. If we get them treated, my employee is going to be a better employee because they're getting more well rested. But the main reason I do it is I want, especially when I was just starting in the dental sleep world, is I wanted to get comfortable treating these patients and knowing how to treat them, knowing the hurdles associated with dental sleep medicine, and how we can streamline that process as quickly as possible. So when we actually do start treating, I call it real patients, real paying patients, we can walk them through that process in an efficient as an efficient way as possible. It then takes off the stress level, of that uncomfortableness when I'm doing it for my first time, when my assistant's doing it for the first time. If the patient we're already comfortable with them, it just takes a lot of stress off of that. And I did that when I started placing implants. The first handful I did for free because they were great learning opportunities being in my practice, and it's how we mitigate these big jumps of these being uncomfortable, and how do we overcome that. And it could be small stuff, like each day I go on a Peloton and push myself, and it kind of triggers my mind to kind of move forward and kind of push back out of my comfort zone, so it becomes more repeatable and I get used to it each and every day. And that's why I kind of think that there's certain moments that we can learn from, and that bungee jumping experience was something that I definitely pushed me out of my comfort zone and started making me become more comfortable. So the thing that technology did was it hit all three of these buttons. And when I see things in my life or in my dental practice that educate me, that invest in my practice, but also push me out of my comfort zone, it's things that I know that I need to do. So these are kind of the three things that I hope each of you take something away from it, and how you can then change and do some things different in your practice to kind of be a little bit more successful. A little bit about myself. I kind of gave you a little introduction about kind of how my thought process is, but I am truly a product of two dentists. Both my parents were dentists. I grew up in their practice. I had my mom who told me she didn't want me to become a dentist, and as a good son, I didn't listen to my mom and ended up joining my parents in practice. And then I had my dad, who, when people asked him what he did, he said he wasn't a dentist, he was a tooth carpenter. And kind of just think of what that mentality is, and I think that's what translated to their practice. Is they were really they looked like he really honed in on that and like loved saying that tooth carpenter word, but it had an impact on the practice that they had, and I kind of grew a little bit frustrated. Every single year we worked together for about 5 or 6 years. And every single year, we were primarily a drill and fill dental practice, one tooth, maybe two teeth at a time. And every single year, we did the exact same numbers. Our revenues were within about 4 or 5% of each year. But if you looked at our profit, each and every year, our profit was decreasing. And I kind of bring up this slide is that as dentists, especially a drill and fill dentist, you have revenues that are staying about the same because of third-party payers, and you have overhead significantly increasing with the cost of wages. But I don't know if anyone has ever looked at what the cost of a box of glove was pre-pandemic, before COVID, what it was during COVID. I think it was like $3 or $4 a box. It went up to like 15 or 20 at one point, and then it's come down a little bit. But their business model of this drill and fill dentist was revenues staying the same, if not decreasing with insurances. We had overhead increasing, and that's not a great business model to be in right now. How I've used technology is I started to add services. I started doing same-day crowns. I started doing clear aligner therapy, and I started doing implants. And the other thing that one really successful friend of mine in the business world kind of told me when we look at overhead is you can't cost cut your way to growth and prosperity. I'm going to say that again because I think it's really important, because dentists focus in on a lot about cutting costs and trying to cut employee wages or keeping them level. I'm going to say it again. You can't cost cut your way to growth and prosperity. So some of you as dentists are dropping insurances, and that can definitely increase your revenue. I think another way of increasing your profiting, increasing your revenue, is by adding additional services to your practice. And when I got into the digital world, one of the first things that kind of resonated with me that I was attracted to was kind of the dental sleep world. If you're using any of the intraoral scanners, I'm glad you are. If any of you have not used a digital scanner, I highly encourage you each to start using it. I'm going to show you some figures later on of just the accuracy of this. Dental labs love, at least the modern ones love that you're using digital scanners because of the accuracy, the precision, and all of the benefits that go along with it. So yes, we can do restorative, we can do orthodontics, we can do implantology, but we're really focusing today on sleep appliances, mandibular advancement devices, oral appliance therapy. And it's just another revenue source that I was able to add by kind of opening my eyes to the dental technology that's out there. So let's talk about kind of if you're just getting into the dental sleep medicine journey. It's not this straight, easy road, this highway in the middle of the desert, 2-lane highway that you can go 70 or 80 miles an hour with. There's going to be some curves and some frustrations that go along with it. I think the easy part of the dental sleep medicine journey is actually making the appliance. I think all of us can take a full arch, upper and lower impression, and capture a bite with a George gauge. If you can't, I can probably teach you in about 10 or 15 minutes to do that. The tough part is walking the patients through this process. One is we have to screen the patient. That's fairly easy. But then we have to deal with the why are you as a dentist screening me and talking about sleep? Like, why are you talking to me about sleep? Kind of have to get over that hurdle. Then we need to get them sleep tested. And we're going to talk about some tips and tricks real briefly today on how we can get patients sleep tested. We then have consent forms, financial forms. Are we doing medical billing? Then we need to make the device. Then we need to titrate the device, and we need to deal with side effects because side effects do happen. And side effects are okay because really the ultimate side effect of not getting treated for sleep apnea can be death or some really significant medical issues. Then we need to do follow-up sleep tests, and then we need to do yearly recalls. The focus of today's lecture isn't on all of that stuff. The focus today is going to be the digital technology, how I've implemented it, why I implemented it, and why I think Panthera will be a great partner for you if you have that digital technology. So one of the first patients I actually screened in my office, we got them sleep tested. Young guy, thin guy, but narrow arch, had some ADHD, on Ritalin. So it wasn't this typical obese male that everyone thinks, especially the medical world thinks, has sleep apnea. It was one of those more subtle ones that I think dentists are great at screening for. Narrow arch, some tongue ties, Mallampati score of 4, and just didn't sleep well. We ended up getting him sleep tested, came back with severe sleep apnea, and we get a text a couple weeks later that he's moving. I don't even get to treat the patient, but I get this in response. I've done a lot of INDs, extractions with big abscesses, pus coming all over the place where I'm truly saving the patient's life by getting the infection out of there. And I don't get a thanks like this. When I just screen the patient and get him tested, I get a response like this. And this is where I know that road can sometimes be daunting and it's not straight, it can be curved, and we can get all frustrated in the dental sleep world. But I knew that there was something to this and I needed to keep on that road to kind of to figure it out and kind of streamline this and get as many patients through this process as possible. So let's talk about just the overall prevalence of sleep apnea in our population, in the US population. These numbers are really overwhelming. I don't like big numbers. I like when we talk about 6 or 7 or 8 or 9 digits. I'm going to bring it back down to, I think, numbers that we can all relate to. If we have a 2 hygiene practice, working 8 hours, it's about 8 patients per hygienist for a total of 16. For round numbers, let's say I have 8 patients on my schedule. That's about 25 patients that come through into my door each and every day. Of those 25 patients, about 12 or 13 of those patients will be snoring. They're not going to say they snore, but they absolutely do snore. And we know that a mandibular advancement device can be the first line of treatment for snoring. So we can help 12 of those patients straight off the bat. Of those 25 patients, 8 of those patients will have sleep apnea, and only 2 out of those 8, or 3 out of those 8, will actually have been diagnosed. So we're looking at 8 patients in every single day in our schedules that we can help treat. We can help. First, we need to screen them. Then we need to diagnose them, and then we can ultimately be treating them. So this is, and we see these patients more often than their primary care physicians. And I don't think there's a better medical professional right now to look at the nuances of the tongue and the soft palate and the teeth that can screen these patients at a much higher rate and a more effective rate compared to our medical colleagues. So we really need to be stepping on the front line of this, and we will often catch these patients before they have some of the side effects. We'll catch the mild and moderate ones by looking at these nuances of the mouth before they become these severe sleep apneic patients, and before they develop all of these comorbidities, the diabetes, the hypertensions, the AFib, all of these things we can catch early and hopefully prevent. And the other side effect tidbit on this slide is of that 3.6% that are diagnosed, I'd say half of them are actually doing the treatment. So there's a tremendous amount of people that we can help each and every day just looking at these overall demographic numbers. So we're down to 8 patients have sleep apnea. Now multiply that during a given week. That's 40 people that are coming into your office every week for a typical dental office practice that we can be screening and treating. So we can have a tremendous impact if we know what to look for and how to talk to the patients. And then just some economic costs real quick. Because sleep apnea can cause a whole bunch of comorbid diseases and the treatments associated with that, there can be accidents, motor vehicle accidents. That total they estimate it to be $150 billion. Treating every patient in the healthcare system would just cost $50 billion, with a total savings to the US economy of $100 billion. That's a huge number. So I'm an advocate, and I'm going to kind of talk about it, is the importance of having sleep tests at dentists' disposal, so we can either dispense them directly or order them, and we don't have to really get the medical system completely involved. And I'll talk about that in a little second. This slide, I think, is the most important slide that I have today, which is really talking about the oral appliance or the dental sleep medicine pipeline. The first thing is, how do we as dentists screen for them? There's the risk factors, the obesity, the cardiac diseases, the strokes, the hypertension, especially if they're on multiple medications. We're looking at their teeth, the size of their tongue. Do they have a scalloped tongue? Do they have a narrow arch? Then we have some questionnaires that we can give them, like the Berlin Stop Bang or the Epworth questionnaire. Once I get about 4 or 5 risk factors, and oftentimes I can see this before I even go to the room, just looking at their medical histories, we're gonna talk about getting them sleep tested. And this is where your hygienists are going to be your best advocates. And another reason why I recommend getting everyone sleep tested in the office, because they can walk the patient through on, I got screened, I have a sleep apnea appliance, and can talk about it firsthand. We then go into the diagnosis, and we can refer them out to a sleep center. We can refer them to a sleep specialist. We can have home sleep tests, which I think are becoming more and more common. And then there's different variations of the home sleep test and how we do that, and I'll talk a little bit about there. We get the diagnosis of mild, moderate, or severe, or no sleep apnea at all. And if they're just snoring, we can then still treat them with a mandibular advancement device. We then, for the mild and moderate patients, we can go ahead and be the first line of treatment for the dentist. Or if they are severe, we can offer them a CPAP, do combination therapy working with CPAP or an oral appliance. Or if they're just not compliant or willing to sign that I am not going to tolerate a CPAP device, we can go then straight to a mandibular advancement device. But we need to know how to streamline this process and remove as many hurdles as possible for our patients. So getting comfortable talking about sleep, getting comfortable about how to screen patients for sleep. How do we eliminate the hurdles of them having to go to a separate doctor, whether it be a primary care physician, or a telemedicine doctor, or a sleep center? How do we get them tested with as streamlined and as quickly as possible? And then we're going to focus in on the treatment here in a couple seconds. I've leveraged the technology of the Intraoral Scanner. I think it's great. If those of you that don't have it, I highly encourage you to get it. But I always say it's how, if you're doing it old school, the PVS impressions, how many impressions does it take to get an immaculate impression, a full arch, upper and lower? If all of you guys are saying I get it on the first time every time, great, awesome. For these sleep patients, the ones with the huge tongue, huge gag reflexes that essentially gag on their own spit, taking PVS impressions is extremely difficult, especially on the first time. Then we're wasting more time by going to take a second, a third, or a fourth. Then we have to do it on the bottom arch, and it takes a lot of time. I'm at a point where my assistants can get an upper and lower arch with our prime scan in about 3 or 4 minutes, and that includes getting the bite with the George gauge in place. I will go in there and set the George gauge, but once I set the George gauge, the assistant takes it over. I also know, looking at some of the data with these companies, is their success rates, the fit and the precision is significantly higher when they're using intraoral scanners versus PVS. And we're also saving a bunch of time. We don't have to ship the PVS impressions to the company, have them pull up models, have them mount the models. I can have the impressions at the lab's hands in literally a matter of seconds via the portals or via email, and they can start making these appliances and get them turned around within literally 5 or 6 working days. So with the intraoral scanner, if something doesn't come out the first time, all we have to do is cut and paste it and take that scan over. We don't have to send the impression back or take a new impression. It can be fixed in a matter of seconds. Just because of one little void or one little discrepancy, it can be fixed in a matter of seconds rather than a matter of 5 or 10 minutes if essentially another discrepancy or another fold or another saliva pool comes in. Now, I'm also a huge fan of 3D technology when it comes to cone beams. One, purely for diagnostic purposes, but two, it creates, and I'll show you in a second on a slide, a great opportunity on how to relate and talk to the patients on why we talk to them about sleep. So this is a patient that came into my office about 2 or 3 weeks ago. She had a dentist of record, and she was just coming into our office just as a dental sleep medicine patient. So she had just seen her dentist about 2 or 3 weeks earlier. He gave her the all clear, everything looked good. She had an AHI of 60, so she's not a great candidate for an oral appliance, but something that I wanted to talk to her about and say, hey, we can give it a shot if you're really up for it, just tempering expectations. But when I started looking at the panel, something just didn't look right on the x-ray, especially on the lower right. So I threw her in the cone beam machine, and you'll see a quick video. These radiolucencies or periapical lesions or failing root canals kind of popped up on 30 and 31. She got the A-OK because the previous dentist, her dentist of record, didn't have 3D technology. If we're making a mandibular advancement device, we want to make sure the foundation is nice and solid so we don't have any teeth that are coming out. And especially if we could potentially be losing 2 teeth, that's a significant amount. That's going to have a significant impact on the retention of this device. So at this point, I essentially, sometimes it's better, we know to say no to treatment is better than saying yes. And I think this is a perfect example. It's like, I don't think you're a great candidate at this point. If we get those teeth taken out, if we get implants in there, or we get retreats and the bone starts to solidify, I think you're going to be a better candidate and you're going to have better long-term success. So I do a fair amount of implants in my office, so I am a little bit more aggressive, I think, than most people when I see these things, because radiolucencies, periapical pathosis is going to continue to grow, continue to get better, and if I want something predictable, and it's kind of like an incipient caries, if I see that breakthrough the DEJ, I'm going to treat it. If I see a radiolucency, I'm going to be treating it, whether it be a retreat or an extraction, because if that grows bigger and it blows out a buccal plate or a lingual plate, now that makes my job much, much more harder to regrow the bone and bone graft it. Or if we lose that, we may not be able to do an implant if the abscess gets so big. So because of this technology, I'm able to see more and therefore diagnose more and therefore treat more. So I'm a big, huge fan of CBCTs. In this particular case, it kind of saved me from walking into something that we just didn't know, that another dentist gave us the all clear when we can really see something going on. The other thing I like it for is, this is a recent article that just came out last year, is they started, researchers, the paper published, looked at transverse dimensions in arches. And they looked at the mesiolingual cusp of tooth number 3, and they drew a measurement to the mesiolingual cusp of tooth number 14 and looked at that transverse dimension. When that dimension was 34 millimeters or greater, sorry, let me take a step back. They then put these patients in the CBCT, measured those distances, and then did what's called a DICE procedure, a drug-induced sleep endoscopy. They then measured, when these patients got put to sleep, how big their airway was, and if there was any collapse, essentially how much air they can get into their system. When they had 34 millimeters or greater in this transverse dimension, there was no obstruction of the airway. When they got to 30 millimeters or greater, between 30 and 34, they started to see an anterior posterior collapse of the airway. And then when they got under 26 millimeters in this transverse dimension, they got a complete collapse of the airway. So people weren't getting enough air into their system. And I think we can assume that therefore they were going to have some higher AHI scores or have some more, have the potential to be an OSA patient. So kind of think of those numbers that I just talked about, 34 millimeters or greater, 30 or greater, and then 26 or less. One of the old school ways I used to measure this was with a cotton roll. I would put the cotton roll in there. The cotton rolls are exactly 36 millimeters, and that's how I measured it. I love having a cone beam because I can get these exact measurements and look at this distance and say, hey, could be a potential another risk factor when I'm screening these patients for obstructive sleep apnea. And then I know this is not diagnostic at all. This is only one snapshot, but this is a great visual aid. In my CT software, we're able to map the airway, and it gives us what I call this Doppler radar effect of how big the airway is. Is it a snorkel or is it a coffee straw? If it's a coffee straw, they're not going to be able to get a lot of air into their system. And I don't diagnose or treatment plan according to this, but it's a great visual aid to explain to patients why I'm talking to them about sleep apnea. Is it the tongue? Is it the soft palate? These are all areas that dentistry is involved in. So why I've loved digital technology and how. And then diagnosing. I know this is a little bit of a gray area, maybe a little controversial, and it really depends state. But having the access to a sleep test, I think, is crucially a critical component of kind of walking these patients through the sleep apnea pipeline that I kind of showed before. If you're in a state where there's vague or rule or wording in their laws that really don't address it, a lot of dentists now have sleep tests and are dispensing them. If you're in a state, and I call it the end states, the New York, the New Jerseys, the North Carolinas, where you're not allowed to have a sleep test, I highly recommend using a company like sleeptest.com, where they set up telemedicine and they can streamline that process as quickly as possible. This is a sleep test I use. It's Brabon. Brabon also has the ability to do telemedicine visits where they set you up with doctors, certify the sleep test, and kind of really streamline that process. It also helps if you're in a practice that's doing a lot of dental sleep medicine, instead of referring them out back to the sleep doctor, we can then do the post-op visits or the post-titration visits as well to see if this mandibular advancement device is working. So a little bit controversial. I know the American Academy of Dental Sleep Medicine is really stepping up and going to bat for the dental sleep, the sleep medicine dentists out there, saying this is something that all dentists should have. I know the ADA is kind of following suit, as well as saying maybe dentists should be having these tests and being able to dispense them as long as they're doing it the right way and getting medical doctors in the loop and getting them certified that way. So let's now shift to the actual treatment phase. I'm a big fan of Simon Sinek. He's a motivational speaker, a business speaker, and he always talks about the why. What's your why? Any business, or let's talk about dentistry, is what do? We all do the same thing. We all try to fix teeth. How we do it is slightly different. There's some subtle nuances in how we prep a tooth, but it's generally the same thing. It's why we do it can be completely different. Each of us have our own experiences. My why was to grow a digital dental practice that allowed me to expand my services, improve my efficiencies, but also create a dynamic patient experience. That was kind of my why, with digital dentistry as the focus. When I find other like-minded businesses, I get attracted to them and want to kind of work with them and partner with them. Panthera has that same model. They have that same philosophy, and they've brought it into the dental sleep world. They've used the best digital technology to create a very predictable, very strong, best-in-class mandibular advancement device. So the rest of the day's lecture is going to be focusing on Panthera, all of the customizable features, and why I love being able to give those patients a Panthera device, because it's just very predictable, very strong, So a quick case study here is there was a multi-center dental sleep medicine practice. Now, this is a huge dental sleep medicine practice. They did 7,000, almost 7,300 sleep appliances over 2 years, and they delivered 15 types of mandibular advancement devices. What they found out was that the initial, and my assumption here is because this study was done a couple years ago, they were taking traditional PVS impressions to get this. That's my assumption. But the average initial remake for all of those devices was 22%. Of those 15 devices, Panthera was one of them, and Panthera's initial remake rate was 4%. I now know, talking to the people at Panthera, their remakes, when it's just digital impressions alone, are down in like the 1% rate. So that's why they love getting intraoral scans from you. I love giving it to them because its predictability is through the roof, and it's so much quicker in any way, shape, or form. And it was also the lowest among all the 15 appliances that were fabricated by this dental sleep medicine practice. They then did a couple years follow-up and looked at all the times someone came into the office with a breakage or something that needed to be sent back to them. If you haven't been into the mandibular advancement device world, things break. These people are hard on these appliances. The average was 39% of the appliances at some point during that 2 or 3 year period needed to be sent back to the lab to be remade or fixed or essentially fixed. Panthera was again the lowest at 13%. So it was the lowest among all of the 15 appliances. So what that told me is that they had the best initial fit with the fewest long-term problems. So they're predictable, strong, thin, super thin and super strong are two key things in the dental sleep medicine world. And then they're completely customizable. You're going to see all the different features, and it can sometimes be overwhelming, but when you learn the nuances and when to use each of these appliances, they really come in handy to give the patient the best possible outcome. So I hate remakes. It essentially becomes the procedure becomes no longer profitable. So if I have something done right the first time, that's the best in my eyes. So when I see these numbers, I'm really happy that I've kind of picked Panthera as my go-to appliance. So now that we talk about treating them, Panthera has 2 different appliances on the market. One has been on the market for a long time. It used to be called the DSAB, the Digital Sleep Apnea Device. They just kind of rebranded it to what's called the Panthera Classic. So if you hear me go between a DSAT and a Classic, it's because I'm learning the new verbiage as well. And then they have on the left a Panthera X3. The X3 is a 2-piece dorsal fin appliance that we'll kind of start talking about. The indications for both is if you have a crossbite, you're going to probably lean more towards the X3. And we're just looking at kind of retention here on when each of these appliances have the best, kind of the best scenarios for them. So with the traction device, if you have short, fragile posterior molars, it may not be a great candidate for you. So then this is where the X3 comes in handy. So if there's absent, fragile, or short lower molars, the X3 is going to be great for you. The other thing that puts a lot of force on the traction devices is the upper canines. So if you're missing those upper canines or first premolars, the X3 is for you. For your patient, I should say. For the Classic, if you have an open mouth, because of the bilateral traction, it pulls it forward but also up, it'll have a tendency to keep those lips closed to get better nasal breathing. There's some research, some lab side research that shows it decreases some sensitivity and pain on the muscle of the TMJ and the muscle of the mastication. The Panthera Classic can be very slim and trim on the lingual, therefore giving the tongue more room. And then some of the reasons where the X3 may not be the best appliance, that's where the DSAT comes in handy, which is the absent, fragile, or short upper molars, and then absent, fragile, or short lower canines and premolars. So it really starts I'm going to harp on this as well, as it starts with a digital scan. We take a digital scan of the upper, we take a digital scan of the lower, we put the George gauge in, get them in a more protrusive bite, get this bite, and then send this off to a lab. In a matter of minutes, the lab can start working on this. If we're going to be, we send that all over to the lab, and then we go to pantheradental.com and we start filling out the prescription sheet. Panthera does more than just sleep appliances. They do a bunch of implant parts and pieces as well, but we're going to focus in on the middle here, the sleep part of it. And we have the choice of making the DSAD or the Classic or the X3. We put the patient's name and information in, a case identifier, so if there's a particular number that goes with the case. And then we have the option of, are we sending them impressions? Are we sending them models? Are we physically uploading the STL file to them? Or we have what's called the Intraoral Scanner inbox. So I am in the CEREC world. So there's something called the CEREC Connect, where we can digitally send Panthera our information, and it's all done seamlessly. And on the back end, I click this, and they will then look for that file in their inbox that way. If there's any particular teeth that are fragile, we can let them know, and they won't put as much retention on that particular tooth. And then with the George gauge in place, that protrusive bite, there's a couple models or couple theories in the dental sleep medicine and how we set the George gauge. I'm of the theory, or how I was trained, is that we want to do max protrusion, max retrusion, or retrusion, protrusion, and then set the beginning bite at about 50% and then work our way forward. If you're in that theory or in that model, you're going to be in essentially option number 2, where it says protrude 5 millimeters forward, or option number 3. There's another theory out there that we're going to set the George gauge as far forward as they possibly can go. We're going to take the bite with the George gauge, and then the lab will move them back about 4 millimeters. If you're in that mindset or been trained that way, then option number 1 is going to be great for you. So just different theories on how we set and where we're setting the George gauge, so they can design it differently to give you the best maximal output for your patient. They give you some options, is the vertical spacing, and the great thing is about Panthera is you only need 2 millimeters of vertical spacing, so we can have that George gauge of 2 millimeters. We don't need to go all the way up to 5, which a lot of the appliances need, so we can keep it nice and slim and trim. And then is the maxillary protrusion straight? Did they come straight out, or are there any deviations? And if there is any deviations, we're going to select yes. So all of a sudden, if the midline is off by 0.5 millimeter or more, I will select yes. And if the midlines are nice and even, if the midline is off, we're going to select no. If it's straight and the midlines are straight on, we're going to select yes. If there's not enough retention, just like we do with Invisalign or SureSmile, we can add buttons if need be. I always put elastics on because I'd rather have the option to use elastics rather than wish I needed the elastics and then have to send the case back. And then if you have third molars, do you want them covered or not? So a whole bunch of customizable features. I think these are very typical for most dental sleep medicine, dental oral appliance or MAD devices. This is where I think Panthera truly shines. If you're just getting into the dental sleep medicine world, I'm going to highly recommend that you use optimal values for both the plateau and band. If you have some nuances here and you know your patients and are starting to figure things out, then we can start going into the customized features. And this is where their CAD/CAM software that Panthera has really shines, because none of the other, at least that I'm aware of, have these features. So these are called the plateaus. Is where do we want this device to essentially meet? They have all these options. Where is it lateral on the maxilla? Is it full, or is it only anterior? For the lower, they can do lateral or they can do full. These are options, and I'm going to kind of briefly talk about why I select each one when I select each one. We then also have bands as well, and we can go to click Customize here, and then it gives us a whole bunch of customizable options on how we want the appliance to fit. Do we want just buccal? Do they have some huge tongue and we want to minimize as much on the lingual as possible? Or can we do full, or a half lingual, or half buccal, or a lingual only? These are all features that I haven't seen with any other device that can come in handy, because if you don't know that you need them until you have a case where you truly do need them. And then on the lower, the exact same things: a half buccal versus a full versus a lingual versus just a buccal. All of these things are great tools to have if you need them. So the Panthera Classic or DSAD, super strong, super thin, really unbreakable. I have yet to see one break. We don't need any ball clasp. We just use the natural undercuts of these teeth. And because of the traction device, we're able to decrease the TMJ pain and also the muscle fatigue, and we're able to keep the mouth closed or create a lip seal to help facilitate nasal breathing. So this is kind of the benefits. We're just talking about a bilateral traction device. So the pull device versus a push device, which is like a Herbst appliance. These are all on the lab side of like the bioengineering on how they get these numbers. But the traction device, we know that on the lab side of things, there's 10% less stress, and it then closes the mouth to get that lip seal and helps to breathe through your nose. There's 30% less stress on the muscles of mastication. And I've seen this in clinical practice. I've seen patients tolerate bilateral traction devices at a much higher rate compared to the Herb style or the push type of appliance. And then we can also remove some of the pressure from away from the incisors. The incisors are always the weakest teeth. And if there's no pressure there, there's no stress, and we have a decreased amount of tooth movement, or a reduced risk of that. So the retention is on the posterior teeth, the stronger teeth. We have the anchors and the rods and how they lock into place. I don't think there's any way, shape, or form these patients can pop these rods out in place, or they're going to be doing some aerial acrobatics with their jaw. We have the plateaus, and then we have the elastic notches. The rubber band can fit in here, and then you wrap it around the rod if you're going to be doing using elastics. And then this is where all of the different plateaus come in handy. This is the most common, which is a lateral on full. It minimizes the pressure on the posterior and minimizes the stress on the TMJ, while also getting a little bit of an opening for the mouth if they are going to be doing mouth breathing. There's the full on full, where if we really need a lot of retention for these short teeth and we want to kind of distribute the forces, we can do full on full, which is how a lot of the mandibular advancement devices are kind of designed. I think these two are where it really shines. If we have these big bruxers and we need to try to eliminate how much they're putting forces on these appliances and on these teeth, what I've learned is if we can get them to do a more anterior edge-to-edge bite, which we can design with this anterior on full, we can start decreasing the forces that they put when they clench. So the analogy I use, if I have two soda caps and I push them together, I can generate a lot more force when I squeeze down. If I have two marbles and I try to squeeze down, I can't put as much force on that. So we can get this more of this anterior guide plane and anterior contact in the front. We can hopefully decrease the amount of force they're creating when they clench or grind at nighttime. And also just getting them in a more anterior position, a more protrusive position, we can hopefully get them to sleep better, and then therefore also decrease the clenching and grinding. And then those patients that have complete nasal collapse, where they can't breathe at all through the air, we can do lateral on lateral and create this little air hole in the front so patients can breathe a little better. The titration rods come in 0.5 millimeters. And then if you have, for whatever reason, someone that has broken these rods, they can then send you a series of what are called heavy Bruxism rods. This is where I think Panthera truly shines, is all these customizable features that I have yet to see in another sleep appliance. We can then focus in on the X3 and some of the benefits to this real quick. Is that it's a two-piece, and the reason I love this two-piece system is it's not 2 pieces, but then a whole bunch of multiple other trays that you have to fit. So if all of a sudden it's tight on a particular tooth, I then have to go to every other single tray and adjust that particular spot. With this particular system, I have 1 tray, and if it's tight in one spot, I only have to adjust one spot. Because of this clip housing, with my fingernails, I can pop this out and then put another one on, and it's titratable, so there's no additional tools. It's just me with my fingernails putting this splint in and out, this clip in and out to then move the patient more forward and titrate them. Again, with their 3D printed nylon, super small, super lightweight, super strong, all custom made. Same kind of process. Retention is from all the undercuts, and the more accurate model you give them, especially when we're talking about 3D, the more accurate appliance that they can send back to you. And no tools required, no little thing to kind of move it forward. And all of these can be titrated at the 1 millimeter mark. And then they have that 20-degree plateau to ensure that everything locks into place and it doesn't jump back over, and essentially they're not occluding or not protruded like they're supposed to. Again, all of the customizable features that the DSET have with their bands and their plateaus are with the X3. So really this can be kind of your one-stop shop if you need to and kind of are starting with one particular company, one particular type of one company. You have 2 different options to create an amazing array of different customizable features. This is just the indications kind of for both that I showed earlier. And then recently they just came out with a night guard. So if you are making night guards, super streamlined, super thin, all done with the kind of the same process. Same material as the DSAD, the Panthera Classic or the X3. Same CAD/CAM proprietary software. Full arch, flat plateau. You can kind of put the lings where you want to. There is no ramp at this point, and you can then also pick which teeth need more protection or less retention if there's some particular teeth that are a little bit more mobile, or not, I shouldn't say mobile, but just are a little bit more fragile. For those of you, there's a great introductory offer right now where they're offering 50% off your first Panthera night guard. You can go to pantherasleep.com/nightguard promo. You can also scan this QR code, and it'll go directly to that 50% off. I just found out about this week, so I'm looking forward to using the 50% off code for myself. This is my contact information. That's my personal email address, my Instagram. And then I am involved with a company called CDocs. It's an amazing education facility. It's a sister company to Spear Education. They share the same building in Scottsdale. Well, I will be, I guess you're the first group that I can announce it to, that we will be starting in late August, early September, in-person classes on how to implement dental sleep medicine, oral appliance therapy, mandibular advancement devices, in person, and kind of teaching you that through a couple-day workshop. So, I'm open to questions. I'm going to kind of keep this page up for a couple more minutes, and then I'm going to scoot back to the QR code. So if anyone didn't get a chance to take a picture of that QR code, they can.
Great. Thank you, Dr. Ford. That was really, really good overview of all that stuff, plus ending it with the quality devices that people can start with.
Yep.
I have a question for you. A real popular question is about billing. Everybody wants to know how to get paid for this. And in your talks, do you talk about that? Do you go over like private pay versus insurance pay and all that kind of stuff?
Yeah, we'll definitely be talking about that. And it's going to be a combination of everything. It's going to be a combination of how do we set up firm financial relationships. Even with my medical billing patients, I still require them to put some type of down payment before they leave, before we make one of these appliances, because I don't want to go off into the abyss and think medical is going to cover something and they don't. But we're going to talk about medical billing, and because we're talking about dental sleep medicine, and I stress medicine. We can bill medical insurance for this, but we also do cash patients as well. So we're going to have talk about all of that in those lectures.
One of the things that you showed pretty clearly was how many choices there are on how to do a Panthera appliance. So you can choose what kind of overlap you have for the front teeth, and the platforms were the easiest part. Can you talk through just a little bit about the front teeth and the way that you choose the fit of the bands across the front? Because in my practice, that's a pretty big deal to make that just right for patients. And so just talk about the front teeth for a moment.
So the front teeth, if they have some huge tongue, I want to eliminate as much material on the lingual as possible. Okay. So I will either just put a buckle on there, or I'll maybe put a little bit of an overlap just to keep those teeth a little bit more stable, kind of keep them in place so they don't move. If they are more of a mouth breather, I will then kind of make the bands, and sometimes the bands and the overlap kind of coincide with one another. So sometimes they're mutually exclusive. So you can always tell them in those notes what, if you're just getting into it, what the patient is and how to mitigate some of these circumstances and give the patient the best option for the benefit. Is sometimes we'll just create then an opening in their mouth to get as much volume and as much airway in there as possible. Okay.
I got to say that I had the great good fortune of visiting the manufacturing facility in December, and they have a very robust artificial intelligence driven software, but every one of these devices is finished the design by a human. So when you put in your request for a special arrangement for these front teeth or that platform, there's a real human artist that's going to take that request and make it happen.
And that's the thing with technology. Technology is great, but we still need to have the human knowledge and the whereabouts to direct the technology in the right way. So it's kind of leveraging both to give our ultimately the patients the best overall treatment and outcomes.
Yeah. One of the comments made here was Stephen Bray says, "Thank you for an excellent overview. Used milled appliances for years, and they're definitely head and shoulders above all the else. But these aren't milled. I just want to say that these are additive technologies and built up from powder using lasers. And so these are even more precise than any milled.
I was using milled for a while, and then I've started to see some of the milled appliances come back broken, where these arms are breaking, and that's where that's where I think Panthera shines. Is I don't have these issues. I really don't come across any of the issues because of the predictability and the strength of this material and the 3D printed technology that they've created, this nylon material.
That's right. And say just a little bit more about bruxism, because we have a lot of patients, you and I and everybody that does this, who grind their teeth at nighttime. And so you build these to help withstand that as well.
Yeah, so that's where I will then go on the more anterior plateau, kind of get them the pressure more on those anterior teeth. And I go back to that analogy. If I try to squeeze as hard as I can with two marbles, because of the pinpoint precision of that, I can't. Where if all of a sudden I get two bottle caps and I press down, you can press down a lot harder. I haven't seen another appliance been able to customize features like this where we can get more of an edge to edge and hopefully decrease the amount of pressure they're putting on this. If they're decreasing the pressure on these appliances, they're going to last a lot longer. I know there's also some research that shows if we get them sleeping better and breathing better, we also know that the clenching and the grinding and the bruxism goes away too. So it's working hand in hand with both.
And that leads to fewer side effects.
Correct. Yeah, absolutely. Less pressure on the muscles of mastication and less pressure on the joint.
Exactly. Simi asked, are they printed?
Yes.
You know how they're made?
3D, I mean, I know how my 3D printer in my office works, which is lasers, and they kind of build it up off of a platform. So I'm assuming it's the same thing, just in a much easier way.
It's a much more advanced type. Probably falls in the same category as what you might think of for a printer, but they're a long ways away from the 3D printer you can buy.
Offices.
Yeah, it's not even close. Yeah, so it's so that just speaks to the quality of the device. You know,
we can't put this material in our offices.
There we go. You can't do that. That's correct. Yeah. Well, that's there you go. Thank you for putting that back up. We're over our time now. We want to honor everybody's time. So thank you so much for this great webinar. The replay will be available. We'll have the recording available to everybody. We're going to send everybody a link, and we want to especially thank Panthera Dental for sponsoring this webinar and for you to be able to spend your time with us here tonight. So thank you, everybody. I appreciate you.
Have a great night.
DentalSleepPractice.com sometime and have a look at the replay for this as well.